Over to Dr. Marianne McCallum, who is a GP clinical academic fellow who's passionate about primary care being at its best where it's needed the most.
Indeed.
And what we want to try and do is think about how we can look at inequalities through the lens of improvement. Thank you.
So good afternoon, my name's Marianne, I am a GP. I do my clinical work literally 5 minutes down the road at Clydebank Health Centre, and I'm also at Glasgow University where I have just finished a PhD looking at individual and community factors that influence how people manage multimorbidity in the context of poverty. And as Sonia was saying, I'm really passionate about what the role of general practice can be in reducing inequalities in primary care. Now, I realise I don't imagine anyone here is a GP, so I'll be talking about inequalities sort of from a GP lens, but basically talking through some of the stuff that I've maybe learned over the years to give you guys some ideas about how you might want to apply that in your situation. And I just want to acknowledge my colleagues, Peter, David and Carrie, and the team at GPs at the Deep End who've contributed to this. So I plan to briefly talk through inequalities in Scotland, though you've had a great introduction. And I'm really focusing here on the social factors and how these social factors influence how our patients are presenting, or in many cases, not presenting. How this in turn influences their health in ways that are often hidden to us as practitioners. And therefore, how do we, and this is often inadvertent, I don't think any of us are going into work to say, what can I do to increase inequalities? But actually, how do we sometimes do it without realising it, either maintaining these gaps or widening them? I'll briefly talk about GPs at the Deep End, just so that you know where we're coming from, but also maybe just to say that groups of clinicians can get together, your voice is stronger as a group, and it can be an important advocating organisation. And I'm going to finish with what me and my colleague Peter, who's one of the other Health Improvement Scotland GP Inequalities Advisor, are going around telling people to think about the 15% solutions. So briefly, we've got a horrific mortality gap in Scotland. For those of you who are not from the West, this is Glasgow. It's a train line. On the train journey from Jordan Hill up at the top, along that green line to Bridgeton, your life expectancy drops by about 11 years, which is shocking. This is a 6-mile journey. It takes about 20 minutes. It is horrific. We should be it's just horrific. But the thing is, quite often when we talk about inequalities, we focus on individual behaviour choice. And this slide is really complicated. I do apologise for it. But what it shows is, what are the excess deaths along the life course caused by? So starting at childhood, for example, accidents are a big thing. And I just want to draw your attention to this, because it's the people who are dying young in their 20s and 30s that really drives this gap. And it's pretty much been driven by suicide, alcohol, drugs and violence. These are socially mediated problems. We should be able to do something about them if we wanted to. This is not about people in poor areas not taking margarine instead of butter. This is primarily about some of these, particularly when you're younger, things that start to get put in place, very much socially mediated, that have a massive impact on your life. So I know most of you are coming from a paediatric point of view, so I'm sure you will all, I really hope you will all have heard about ACEs, about the impact of what I tend to I prefer to say childhood adversity or childhood trauma, because there's more than 8 bad things that can happen to you growing up. And my job as a GP is actually full of looking after the physical and mental and social impacts of earlyhood trauma and how that affects your health as you grow older. And because I was talking about a few statistics, these are just some basically from childhood to adulthood in almost every area. If you're poorer, you're going to do worse. It's not good. So why do we need to consider equity and patient safety? It's not normally something that we go to in sort of patient safety circles. And there's 2 reasons why. The first one is that most of the things that are driving these inequalities are invisible. They're not necessarily really obvious to us, and they're not always things we can easily measure. Therefore, if all we do is measure the stuff that we can see, we're never actually going to get anywhere. We need to sort of take a step back and think. And if all we do is measure what's easy, then again, we're not actually going to improve the outcomes for the people who need it the most. In addition, for the clinicians out there, I think the reason we need to consider this is because actually, as Izzy was saying really well, these are generally the patients where you just are leaving at the end of the day feeling, gosh, we're really letting them down. I'm finding it hard. You know, those times when you leave work and just think, gosh, that particularly for children, that child, you know, we're really letting them down. And that has a real impact on our ability to keep being compassionate, to keep turning up. So actually, if we can start to be thinking, well, look, rather than feeling helpless, what are the things I can do? I think that's helpful. And I think that keeps you going. So I'm just going to briefly talk on some of the things I found out in my PhD, which is looking very much at a deprived area in Glasgow and how that impacted how they manage their health. And this is all adults. The first thing was the impact of these really important shared community experiences. So in this area, people talked about being known. They knew their neighbours knew them. The community was actually quite a safe place and people helped one another out when things didn't go well. But they were also known as being from that area, and all of them experienced stigma in all kinds of places. Generally, people would start talking to me saying, oh, I know people say that folk from the area are like this, but I'm not, because they were just expecting me to judge them because that's what everybody does. And finally, they lived in this area where none of the systems worked, and that wasn't just health, that's education, social care, housing. And it's not just that it doesn't work for you, it doesn't work for anyone you know. And the issue with all of these shared community experiences is it fundamentally shifts how you approach health. The likelihood is that most of us in this room are from are currently, if we're here, will be in relatively affluent backgrounds because we're, you know, employed in some way in HIS, and most likely have come from that. So we maybe see doctors and services as safe places, but the people that I work with and the people I did my PhD with don't. These are just another group of folk who just let you down and who don't care. And what that does, it led people to do two things. They either got angry and got banned, which didn't really help us manage their health, or they just disengaged, and that was really common. They either just didn't turn up, or when they did turn up, they just would tell me, oh, I just smiled at the doctor. No idea what they said, but, you know, just, you know, it's that kind of thing, what's the point? And I think the really key thing to say here is that, I mean, this is in general practice, but for us as GPs, it's recognising that we might not necessarily see this. The people who are not turning up at your appointments, there's probably very good reasons why, that you're not seeing. And that is impacting their ability to access the health and support that could really make a difference for them. So I'm just going to run through a theory, because I'm an academic and I love theories. I know most people hate them, and that's totally reasonable. But this is just to give you a framework to maybe start thinking about this, because it's a big idea. So burden of treatment theory. Treatment burden is the work we as clinicians give people. And the other thing you need to know about is capacity. So that's their ability to carry out that work. So that can be whether you've got access to a car, how much money you have. It can be whether you live in a nice leafy suburb in the West End with loads of fruit and vegetable shops, or whether you live in a community like the one I used to work in where there was no fresh fruit and vegetable everywhere. The supermarket was several miles away, but there were ice cream vans that came around and sold cheap noodles and no doubt other illegal substances. And that ability to make healthy choices is actually much, much harder. The key part about this is when the work that we give people outweighs their capacity to do it, poor outcomes happen. And the reason that I'm interested in capacity is I think we rarely think about it. And until I came across this, I have to say as a GP, I don't think I'd ever sat and thought, can this person do what I'm asking them to do? You know, so often we come up with solutions without ever thinking, can this person read? Have they got access to a bus? You know, these things are things that we probably do need to be thinking about. And in particular capacity, it's got 4 parts. Mobilising, these are the resources people have. We don't have much influence over that. Expressing, these are the things that people might, that people have, like whether they can read, how competent they are. So can they actually use the resources they have? Again, we're less able to do much about that, although I think particularly in general practice land, some of that empowering people stuff comes in here. But the other 2 things are important. So control, these are the things that provider organisations do that decide their services. So what type of roles they have in them, what guidelines they have, protocols. Well, we do decide that. And then opportunity. Okay, I've talked more than I meant to. So opportunity, which is different services in different places at different times, whether people can access them. So one of my main things I want to think about is this: health systems are actually designed by healthy people for healthy people. And I'm borrowing my colleague, Dr. Burley's thing there. Essentially, what we've done is created a health service, and when it doesn't fit for people, we blame them and we say they're not engaging. And I would say that's a problem. So what can we do? I want to make it clear, you guys are not responsible for fixing health inequalities. Sometimes in the past, we have maybe been guilty of just making people feel really bummed out. You're not. We've got health inequalities because we've got societal inequalities, and actually none of us can really do much about that because most of these drivers are out with our control. But what we can think about is maybe that 15% where we are in control, where we could do something, where maybe just by not thinking about it, by not stepping back, we have inadvertently increased gaps in outcomes. So what are the parts of the system that are maintaining or exacerbating inequalities in your context? And are we willing to consider factors that aren't really easily visible to us? Are we willing to actually stop and think and look for the stuff that's a bit more difficult to collect? So just talking very briefly about GPs at the deep end, this blue and red line, that's the increase of mortality and disease count across the quintile, with number 10 being the most deprived. And as you can see, it shoots up. But the bottom line, that's the amount of GPs you get. It's flat. And that is a problem. So we GPs at the deep end see this gap. This is the gap between what we can do and what we could do if we were resourced by need. It has an academic name, the inverse care law, which I'll just skip over because I'm running out of time. So how did we get our name? We flipped that graph over, and somebody said it's like a swimming pool. And so what you've got are, you know, some GPs whose feet are touching the floor, and then those of us at the deep end struggling and just overwhelmed. And so that's where it came from. So as a group, we've done lots of things. We started things like the Links Workers Programme, which some of you might know about. We started financial inclusion workers and practices, which has now been rolled out nationally. We have our chair, who's incredible, who has now got a permanent role in Scottish Government advising on primary care inequalities. And we continue to advocate and work together to look at ways in which general practice can be at its best where it's needed most. And it's been really life-giving as well, I would say, for a lot of us who are exhausted on the front line, just coming together and realising that that experience of, like, this isn't working, can no one else see that this isn't working for my patients, is actually shared. And then the power when you have lots of us pointing that out works. So as I said, I've got a role with HIS as an advisor on inequalities in the primary care faculty. I've got another colleague, Peter, and we've done talks along this theme to a few different groups. This is our 15% solutions from a primary care point of view. So record and monitor unmet need and demand. Start thinking about the difference between need and demand. So the people who are able to access the service and are causing the most problems are maybe not always the people who need it the most. And how do we make sure those people who are likely more vulnerable are still able to access it? Think about the barriers that you can mitigate. So, for example, when I was chatting to the primary care implementation, like our CTAC, you know, are your CTAC centres, your community treatment centres, if the area that you cover, there are bus routes that actually go there. Where I work in Clydebank, there's no bus route to our hospital. So if we've got children or people who need to go to A&E and they don't have a car, it's really difficult, and they don't have money for a taxi, it's really difficult. How do they get there? And it's an unnecessary stress that other patients and other practices aren't having to worry about. These are things that planners could fix quite easily. Potentially hospital doctors could fix quite easily. Trauma and understanding the impact of trauma, recognising that, I don't know how much you guys know about trauma-informed practices. I'm happy to talk a bit more about that. But when people have experienced trauma, then that reaction, kind of what I was talking about, to what seems safe to you maybe isn't safe to them. Thinking about what it's like from your patients, right from when they walk in that front door, right from when they get to the reception, right from the way the receptionist speaks to them. Encourage culture of personal responsibility. I think that's you guys all over with your safety culture. Design for relational care. That makes a huge difference. I'm just about to publish a paper about how person-centred care and primary care shifted general practice from a service that didn't work to one that was for them. So where people felt that their GPs cared about them, where they had that relationship, they were willing to engage. And I know some of you in the acute sector, you might not have the same time, but actually that relational care is so important, particularly from people who experience trauma. Connect with your communities, that's much more of a general practice thing, and learn how to care with people, not to people.